So welcome everybody to this incredible talk. We are so honored to have you, Dr. Shufelt. I'd like to start by telling everyone a little bit about your background. You are the Associate Director of the Barbara Streisand Women's Heart Center and Preventative and Rehabilitative Cardiac Center at the Smith Heart Institute. Those are at Cedars. You're also Director of the Women's Hormone and Menopause Program. Obviously an expert in women's hormones, heart disease. You have several leadership roles in the American College of Physicians and the North American Menopause Society, NAMS as they call it, and you are a certified menopause practitioner. By the way, I didn't even know there was a North American Menopause Society, and you know that I'm going to be getting involved with that pretty soon. And you're also on the board of trustees there. You're on the editorial board for the Journal of Menopause. And you are directing a lot of research at Cedars around women's heart disease, around hormones and menopause. We're obviously going to talk about that a little bit later. Suffice to say, you are an expert in women's preventative health. And you're also, I'm happy to say, Dr. Extraordinaire of our very own president, Shelley Reed, who is lucky enough to have this powerhouse in her medical orbit. So Shelley, do you want to say a few words before we start?
Well, first of all, I want to say welcome, visionaries, and welcome to Chrisandra Shufelt. I am very fortunate to be a patient of Chrisandra's, and what you're going to experience and hear today is a real, true visionary. And just a personal story to put it in context why this is so important is that I initially started seeing Chrisandra because I had early onset menopause at the age of 37, and it was a real challenge. And then you'll find out that there's a direct link to heart issues. And you get into this orbit, to use Thea's word, and you just really don't know which direction to go. You don't know who to believe. You don't know, you read everything from Vogue magazine to the LA Times. I mean, there's just a lot of literature, but no direction. And so this is going to be a very exciting program today because you're going to see that these issues just aren't issues that affect women at a certain age. They're issues that start at in your teens and go all the way through until you're post-menopause. So I'm delighted to see you, Chrisandra. Thank you very much. She has an extraordinarily busy practice and obligations at Cedars and everything else she does, and 2 big NIH grants she's writing and heading up. So we are very fortunate to have you with us today. So I'll just pass it back to Thea.
Thank you, Shelley. I'm really excited to hear about that research, by the way. As you mentioned, issues that start in our teens that we don't know about are actually affecting our heart and the condition of our heart and are making us more predisposed to heart disease and heart attacks right now. So I'm really excited to talk about that research as well as your menopause research. But first, before we get into your specialties, and also I want to leave a little time to talk about COVID, by the way, because obviously that is the disease of the moment. But I want to roll it back and just start by looking at the big picture first and talking about this idea of bias that we've been chatting about before as we started. It's basically baked into our healthcare system right from the start. So when we talk about implicit bias in the healthcare system, what does that actually mean? Why is it such a systemic problem? How does it manifest in our day-to-day healthcare? Can you explain some of the factors that are playing into this?
Well, first and foremost, thank you for this invitation and to be able to speak to you women today, the visionary women today. And I just looked at your organization and what an incredible group of women from all different areas. And what an honor it is to talk to you about my passions, especially in women's health, and really getting the message out there, especially that we need this, my passion is not only midlife women's health, but also that we need more research for women. So the implicit bias definitely comes back to medicine. And this really speaks to the fact that it wasn't even until 1990s that women were mandated to be in clinical trials. So every drug that is pretty much now generic, because generic patents go off about 10 to 20 years after they hit the market. And you can think of all the drugs that were from the 1950s, 60s, 70s, and beyond, up until the 1990s, were all tested on men. So when I see a woman in my clinic, if I often hear, and it's not anecdotal anymore, doctor, I'm so sensitive to medications. Can you please give me the smallest dose? I I have these, you know, I'm very sensitive. And that's true related, because most of the drugs that we prescribe now have only been studied in men. And so if you look at the last 10 drugs that have been pulled off the market by the FDA, by the way, and that's our governing agency. I mean, we have an FDA for a reason, just like we have an FAA. You wouldn't get in an airplane if you knew there was no fuel in the wings. And the FAA makes sure that we have a checklist. The FDA does the same thing. So when you do a clinical trial, what you're doing is you're identifying how that drug works, if there are side effects, and is that an effective drug compared to what's on the market available today. So you have different phases of clinical trials, and then it hits the market. Well, if it's not been studied in a woman, you're going to see what I call the phase 4 of a clinical trial, because phase 3 passes. Phase 4 is really what's out there in the general population and the general public. So if you look at the last 10 drugs that have been pulled off the market, 8 of the last 10 have been pulled off for side effects in women. And these aren't side effects like nausea, you know, vomiting, stomach aches. These are pretty lethal side effects like arrhythmias, stuff that I consider and I see in my clinic. Arrhythmia. An arrhythmia is an irregular heartbeat that can kill you in terms of you drop dead of a heart attack or an abnormal rhythm. Now, is that, you know, obviously the FDA monitors things very closely when drugs hit the market, but you can see 8 of the last 10 drugs for very serious side effects, predominantly in women. Now, why don't we have doses? If I look on my, you know, I used to pull up my white coat, because when I was a resident, I had all these books in them. Now everything's on our phone, right? So if you look at our last, you know, in my doctor's, you know, how to prescribe medication, there's a program, there's an app for that, right? I go into my app and I put it in a drug name, and I can see what doses are available. It's common, we use it. I don't know every single dose of every single medication. There's only one drug in my entire app that has a dose for a woman and a dose for a man. Every single drug, thousands and thousands of drugs. We have doses for pediatrics. I have an option to go in and click a drop down that I'm a pediatrician, I'm going to dose this for a child. But if I dose it for an adult, it's a flat dose. It's a dose, that dose is the same dose I give for a man as I'm going to give for a woman. So it's not terribly surprising that the last 8 of the last 10 drugs have been pulled off for side effects in women. In terms of my world, to me, that's not terribly surprising. But it is shocking that this information isn't getting out there. Now, what is the one drug that has a side effect, that has a dose for a man and a dose for a woman? Well, it's Ambien, and a lot of women take Ambien to help you sleep. Ambien is the only one that has a dose for a man and a dose for a woman. The max dose for a woman is 5 milligrams. The max dose for a man is 10 milligrams. And why is that? Well, Ambien metabolizes very different in a woman's liver than a man's liver. And how we metabolize it is how long the medication lasts in our body. And if you think back almost about a decade ago, there was probably a little bit more than a decade ago, because I was a resident, and there was all these reports of people sleepwalking, sleep eating, and even more concerning was sleep driving. And these were people that just did not know that they were doing it. And you go back to that data, those were predominantly women. And that's when the FDA said, well, we need to look at the data. And if you look at the data, how it was just presented to the FDA to get approved, which is like a book, it's huge, the amount of data that has to get presented. We wonder why drugs are expensive. A lot of research has to go into that. There was one study where it was broken down into how it was metabolized in a woman and a man. It was overlooked. It was not taken into consideration. It was a rapidly different metabolism in a woman than it was in a man. And therefore now, only now, have our first medication that's dosed for a woman and a man. So my calling is, why do we not have more? If we have got, women are not little men, right? That's another thing I often say. We are not little men with reproductive organs. We are different. Every cell in our body has a different genetic makeup. So a long answer to your implicit bias, but the first implicit bias is we got to start with the research.
I mean, it's really astounding when you realize that women, they only started using women in clinical research in the 90s. So if you think about all the research that's been done before that, I think 1990, mid 90s really, all of it was done on men. There was a standard of clinical research, and it was the, I think, 154-pound male. And they just left everybody else out. And one of the reasons you explained that they left everybody else out is because, you know, women are too complicated to do research on because they've got hormones, and that affects the variance of their hormones affects the outcome of the studies. Well, duh, we do have hormones. And so, you know, that is something that was shocking to me, that we, you know, they basically have left women out because made it too difficult to put women in the study.
Difficult. And what do you want in a clinical trial? You want you want somebody that's compliant, that's going to take their medication, and you want somebody, at least this is from what they've told me, the drug companies, not me with the drug companies, but what the FDA has said when we had the FDA commissioner come out to Cedars to give one of our talks, is that when they asked the drug companies, why are you not including women? And they shared a roundtable discussion with some of the heads of major pharmaceutical companies. And we have to partner with them to really understand this. And it's because women have hormones. And not only do we have hormones, we have different stages of hormones, and we have the possibility of becoming pregnant. So you don't want to enroll women that might have these outcomes, call them outcomes, or side effects that are associated with their hormones.
So basically we've been invisible in medical research essentially, and the outcomes have been, you know, terrible for us. It's funny that you mentioned Ambien. If you really wrap your head around the fact that that's the only drug that has separate dosage for men and women, I'm shaking my head because I actually was speaking to a friend on the weekend who is a tiny little girl. We were talking about Ambien. I hadn't used that. I used to host a morning show, so I would use it then, and I hadn't used it in ages. And she's told me that she still uses that drug. And I don't know how we got into it, but I asked her, well, how much do you take? She goes, oh, I take 10 milligrams. And so here's a woman who has, you know, a excellent healthcare, as far as I know, and she's taking double the recommended dose because her doctor is not aware that there's new dosing recommendations for women.
Right, and it's not the doctor's fault. It's because these doses now had to change after the fact, after they hit the market.
Right.
If you already, you know, if you came out, if you're a physician and you prescribe this, it's more about educating, but it's also that the guidelines kind of change midstream.
And also publishing, right? Because it's one thing to do this to studies, but people still aren't publishing the results. So they might get the results, but if the biomedical research papers aren't publishing the differences that they saw between men and women, you as a doctor can't see what the outcome is, and knowing how that medication is working differently than men and women in the trials.
Exactly. And now, so the calling now is that if you have NIH funding, so our tax dollars are paying for me to do research, for very good academic centers to do research. In areas that are of interest. Now, if you're doing research and it involves an animal, it involves a human, you have to you are mandated to report that data by sex. And by sex, I mean, we have an XX chromosome and there's an XY chromosome. That's different than gender. Gender is what we identify by wearing, you know, what we wear and how we act, and that we identify as a woman, but a sex difference is a female versus a male. And so all research now is mandated, whether you're looking at animal research, because guess what? They looked now back at the research that was being done in animals. Even back then in the 1990s, we think clinical trials is a problem because women weren't being studied in the clinical trials. They went back to the animal models, and the female animal models were not being studied. That's how basic it got. They were using male animals. So now if you're doing cellular data, if you're doing animal data, or if you're doing human data, you have to report it. Now that doesn't mean that it's gonna make the biggest publication, but it's good, at least the data is out there and it's available now. So these are the strides that have been done. And this is what's been happening since the mid-1990s. So
it's good for us to be aware of the history of this, and because the takeaway for us, I think, in this moment is to just know whenever you are prescribed any drug, right, to ask your doctor, has this drug, is there a recommended dosage for men and women? What is the difference, you know, et cetera. I mean, listen, we have to do more things to advocate for our health, and it's not just drugs and dosages. We are, here we are, we're half the population, we have the biggest role in caregiving, but we're not being treated equally. We have higher rates of misdiagnoses. We have higher rates, shockingly high rates of later diagnoses. One study out of the University of Copenhagen just showed that in Europe, women on average are diagnosed for diseases like cancer and diabetes 4 years later than men. Think about the damage that's happening to your body in the 4 years that your doctor is missing this diagnosis. Our symptoms are under-recognized by our doctors, and we just have higher rates of female patients that are told, oh, it's all in your head. We get dismissed as complainers. We're accused of being like, we're over anxious, or you're depressed. I'm sure some people have heard that. Oh, it's all in your head. You need to see a psychiatrist. And all of this is leading to poor outcomes for women's health.
Yep.
So what does it take to change that?
Yeah. So while that study was done in Europe, in Denmark, I would not be one surprised at all if that was similar as what was happening here in the United States. I mean, the beauty of Denmark and the beauty of a lot of the European countries is they have these huge registries, and they know where people are getting their medication, where they're getting their treatments, and where they're getting, because it's a national registry. So they can actually conclusively say this person was diagnosed with cancer at this day, and this female was diagnosed with cancer 2-3 years later. The United States does not have that ability, but it would not at all be shocking to me if that was similar here. So I say we have to be our own advocates, was the first thing you said, but we also have to kind of trust our gut. That's the one kind of take home. Like if it doesn't feel right, and I've had so many women also tell me this, I am in a women's heart center. Why do we have a women's heart center? Because heart symptoms are different than in women than men. And if I had a woman tell me, oftentimes they seek our opinion because we are a tertiary center of excellence, which means that they've probably gone to several other doctors. And it's not surprising that I've heard women say, I went to the gastro doctor, I went to the cardiologist, I was told that it was fine. I went and now I'm at the psychiatrist's office and he gave me this medication. So if I had that recording over and over and over again, I could tell you I've heard it plenty of times. I even heard of one story of a woman who was walking on a treadmill, which is our mechanism of doing a stress test, which by the way, that stress test is called the Bruce stress test. Why is it called Bruce stress test? Because the treadmill stress test is for men. It's designed for ergonomically for the way a man walks.
Right.
At the Women's Heart Center, we don't do the Bruce treadmill stress test. We put women on a reclining bicycle because of the way our blood flows back to our heart, and it can precipitate symptoms more. So she was on this treadmill, not the right test for her. Her husband was in the room. The male physician looked at her husband and said she was having chest pain and said, it's not her chest. This is not her heart. She ended up having a form of heart disease that we were able to identify here at Cedars, but it's trusting your gut, and it's going back and saying, it's okay to get a second or third opinion. If it doesn't feel right, go find somebody else. Go find someone, find a new doctor, get a second opinion, and question your diagnosis or diagnoses. Women are under diagnosed and under recognized as having symptoms. And oftentimes they are told it's all in their head, or what we call psychosomatic, which is the nice term that just means it's all in your head. So, what's helpful for me as not only a patient, but as a physician, is I log my symptoms and I ask my patients to do the same. And if you're seeing a pattern or a trend to your symptoms, there's something real, true related, and you need to seek an opinion. So it's starting with a health journal and really logging those symptoms itself. And then I always say it's not the physician's fault. Oftentimes this starts with educating. And the classic, I'm going to use heart disease as an example, but when I was in medical school, I went to USC, Trojans, and I was in medical school in 2000. We have a classic book on gross anatomy by Netter, which is a very famous artist. It's beautiful. He hand drew all these pictures. And then he does a picture of what would be the disease. So you've got a nice picture of a heart, and then you've got a picture of a person having a heart attack. Well, that person having a heart attack was a man clutching his chest in a snowbank, shoveling snow. So that was what was taught to doctors. And this isn't taught to doctors back in the 1980s and 90s. This was what was taught in the 2000s at an excellent medical school. And so if that's what's being taught, we need to go back and start retraining the doctors. So we've got a bigger issue going on in women's health care. It's not just about having to be an advocate for yourself, but also finding a doctor that really understands that there are sex differences. XX is different than XY in terms of everything. In terms of, we recognize it as heart health here, but it plays a big role in all other areas of a woman's body. And it's beyond bikini medicine. This is where I say it's, the bikini area is your reproductive area, and that's your OBGYNs who are trained surgeons. They're surgical subspecialists, but it's beyond that area. It's now about finding differences in the gut. How we absorb food is different. Isn't that remarkable? How we absorb food. We absorb things like triptans differently than men. You notice the men after turkey dinner, they go to sleep.
Right.
Versus women.
Right.
It's our brain, that's the Maria Shriver's. If she's talking about it from a women's health, brain, dementia, Alzheimer's risk, more women are getting Alzheimer's than men. Not just from the fact that we live longer either. Take that off this table. So every single area of women's health needs to be looked at.
And as you said, so many people, when we think of women's health, and I'm guilty of this, when I think of women's health, I think of my gynecologist. I think, as you call it, bikini medicine. And what is scary about that, there was a study that reported that 45,000 women, and it reported that over half of those women go to their OB-GYN for all of their healthcare needs.
All their healthcare needs.
That's, so maybe they have a cold, they get a sinus infection, they'll get a script for that from their other doctor, but basically all of their healthcare needs are being, addressed by their OB-GYN. And less than 6% of them were seeing a primary care physician for the rest of their well-woman checks. This is shocking and really problematic, right?
Yes, and the gynecologists are excellent physicians, and the well women exam is needed, but it's beyond the well women exam. It's working with other areas of specialty that include heart health, that include bone health, that include vaccinations. It was just 2 years ago now, 2018, our guidelines changed for blood pressure. Now, if you don't go to a good primary care doctor that's keeping up, and we have to do medical education as other areas like legal, you've got to do legal education if you're an attorney. So we got to keep up on the guidelines. But if you're not aware of those guidelines, or if it's not your area, you're a gynecologist, you're not paying attention to the blood pressure guidelines. And by the way, when you take a blood pressure, you need to be sitting upright. Your arm should be at your heart's level. And the medical assistant taking your blood pressure should not be asking you, about what medications you're taking, when your last period was. These are not things that you want to be quiet, because just talking can raise your blood pressure. But it goes back to the fact that guidelines changed, and they change pretty rapidly. And the good thing is they're changing now for women's health. We're looking specifically at women in blood pressure, not just men in blood pressure in those updated guidelines by the American Heart Association. But if only 4% of women are seeing a primary care specialist outside of their gynecologist, that gynecologist might not know that. And it's not to their fault. That's not their area of expertise. But you need to have somebody that knows what's changing and what's evolving. And specifically, that's my calling, to say midlife women's health, it's its own specialty.
And how do we find that person, Dr. Shufelt? Because, I have a primary care physician who's a guy. Does this mean, should I be going to see a female doctor? What do we look for? We all, I think, know that we need our gynecologist, and hopefully all of us have a gynecologist. But what should we be looking for outside of our gynecologist to make sure that the rest of our well women checks are done and done properly? Well,
male physicians are fantastic. As up to date, to try to get them on board with the guidelines. But there's actually been one study that showed in an emergency room, if you are a woman presenting into the emergency room, you are more likely to get standard of care treatment if you were treated by a female physician. More importantly, this is what's more interesting. If you went to the emergency room and you were treated by a male emergency room physician, as long as there was a female emergency room physician on that team, you also receive the same set of guidelines. So it's also, but they showed that if it was a male, but a male team of emergency room physicians did not treat to the same level of care that a female physician, emergency physician was, and was specifically for chest pain. So,
wow. So when we get called into emerge, we gotta scream female doctor.
Yeah, so that's scary, but at the same time, it does speak to the fact that we do see that there's differences in care. So, I'm not going to badmouth any male physician or any, my male colleagues on faculty here, but perhaps having a female physician, you might get better care. I think we're in an advantage because we're in a very, very, our demographic area is such that we have excellent care for all physicians. I think that's where I come down to, but we're looking across the country now. You think of a small town in the Midwest, where there's one family physician, and that family physician might now be in practice for 40 years. And he has delivered all the children in the whole, town. Is that person staying up to guidelines? So it's not just about what's happening in Los Angeles. This is really a Richter scale of 5.0 across the country.
And that's when it becomes even more important for women to just be aware that this exists, so that they can, once it's in the back of your head, then you're asking the questions, right? And it's really just, then you're at least able to advocate for yourself, because you can't advocate if you're not aware of the problem. Mm-hmm. It's funny that heart health keeps coming up, because obviously you work at you're director of the Barbara Streisand Women's Heart Center at Cedars. A lot of your research is in heart medicine. And this is an area where, as you mentioned, bias has such an enormous impact on women, just because heart health and heart attacks, for example, manifest so differently in women, and so little is known about the differences of heart health in women. And I went and I looked up a couple stats, and I was shocked by some of these stats. It's the number one, heart disease, first of all, is the number one cause of death in US women, which I did not know, but only 22% of primary care physicians and 42% of cardiologists feel prepared to assess a woman's cardiovascular disease risk. Think about it, 22% of physicians say that they can assess your disease risk. So when you go to the doctor and they're not saying anything about your, heart disease risk, don't think that you don't have it, because that's what I always assume. Oh, I'm fine. I don't have to worry about heart disease. The bias in detecting and treating heart attacks has led to women having significantly higher mortality rates in heart attacks than men. Researchers estimate that thousands of deaths in women could have been prevented had equal care been given, as you were just talking about, between the sexes. It's about those emergency room entries where women come in with symptoms and people don't recognize their symptoms, because heart attack symptoms are different in women or manifest differently than in men. And so when you're talking about a disease where every second counts, if you're having a heart attack, think about the difference. Men get rushed to get to get to the lab, to get treatment, to get the whatever you do when they stick the thing in and they try to, what's that called? You'll explain. But they get rushed. It's called the door to balloon time, when you get rushed onto that is less than half for men, right? So their doctors get them right in there to open a blocked artery. So that could be the difference in saving your life. And sorry, I'm not describing the medical part of it very well, but you know what I'm saying. I think people get the point that, when people aren't recognizing these symptoms, this is why women are having higher rates of death.
We should probably discuss the symptoms, because they are different in women, right? I mean, right. And this is, you do a residency training and then you do advanced training for your specialty. And when I was a fellow, which is the advanced training in women's heart disease, I was on call and I got called by an emergency room physician. And it was a woman who had a heart attack in the past, and she came in with fatigue. She was fatigued and she had an upset stomach. And he called me and he's like, yeah, this isn't her heart. And I'm like, yeah, she's had a heart attack in the past. Why don't we put her on an EKG? Well, she was in the back of the emergency room, and within minutes of me saying that, she was moved up to the front of the emergency room, which is usually where more of the critical care beds are. She was hooked up to an EKG, and guess what? She was leaking troponin, which is it's the enzyme that we start to see the blood rise when we see women have a heart attack and men have a heart attack. Troponin is the blood marker of a heart attack. So what are the differences? Well, predominantly most men and women get chest pain. That's that clutching chest pain. That was that netter picture I described of a man clutching his chest. I call it the classic Hollywood heart attack, which is, you know, you see Al Capone grabbing his chest and falling to the ground, or, you know, that's what we've been taught even in the media about what a heart attack is. Or you hear about people say, oh, I feel like I have an elephant sitting on my chest. Well, that predominantly is not the symptom that women have. Women have more vague symptoms. They have chest pain, that's for sure, but it might not be the presenting symptom. So it could be anything from, and here's a list, and there's a nice pictorial on the American Heart Association of a woman, and she's dizzy. So she's got this, you know, the dizzy cartoon image above her head. So dizziness can be a symptom. Nausea, vomiting, like I mentioned in my patient, that can be a symptom. Just kind of having a burning in your chest. And that's not burning related to acid reflux. This is something that is brought on at non-specific times, perhaps when you're exercising, not after you've eaten that wonderful taco, but when you're actually, you know, it's not consistent with food. It's more consistent with exercise or even emotional exertion. It can have burning. Back pain. We often see women kind of have more, oh my gosh, I feel like something just went into my back. Am I stressed? Do I have, you know, am my muscles tense? So, and then the other, so I say anything above the waist. If it's abnormal, just mention it to your doctor, because heart health is so important. And you're right, women are not aware of it. And we did a survey here in Los Angeles County, coupled with our Department of Public Health, where these were people calling into the public health department pre-COVID, pre-COVID. And we asked them the question, do you know what your cardiovascular disease, heart attacks are the #1 killer of women? And only 40% of women in Los Angeles County knew that fact. So there's much to be done here. And this is where I say women really make strides. Women did an amazing job of making strides in breast cancer awareness. And look now, breast cancer awareness is very well aware. It's the pink ribbon. Now we're making strides to coming up with the red dress, which is awareness for heart disease in women. And I always say we should have like a lollipop looking dress, because it's about breast cancer and heart health together.
And this also is where this area of preventative health and making sure you're going to doctors that are doing more than just your pap smear, you know, that they're checking your heart every year, because, you know, with all those symptoms that you just mentioned, I don't think if I had one of those symptoms, I would say, oh, I'm having a heart attack, you know, dizziness, nausea, and I doubt my doctor would either. So it's really also about knowing, you know, if you have any pre-existing conditions, right? So then you're on the lookout for it. But if you haven't had a doctor that's made you aware of it, or you haven't asked, you don't know until it's too late. Can I hear you? Can you hear me? Oh, good. Okay, I thought I lost you for a second. I want to get to your research on menopause and hormones, but before, I just want to quickly say that we are definitely going to have time for some questions. I'm going to open it for questions because I know people are going to have tons of questions. So if you have questions, please, I haven't been checking the chat, but please send them to me in the chat. And if possible, if you could private message me, it would be great, because then I'll be able to see them just a little bit easier. Let's talk about your research in menopause and in reproductive health, because you're doing some really, really interesting research at Cedars today. And I feel like this is an area of women's health that we hear so little about. And I just had a conversation with a girlfriend actually who told me that she went through menopause and she didn't know until it was over, because she kept describing her symptoms to her doctor, and her doctor kept shrugging her off because she was, you know, I guess they figured was too young to be going through menopause. And she literally found out afterwards, oh, it's done. You're never getting your period again. It's already finished. And all those things you were experiencing, that was it. That's tragic to me. Why are we doing such a bad job at this? And how do we do better?
Yeah, it's a great question. And how do we do better for women's health and menopause specifically? And this is where we do have an area of expertise in the North American Menopause Society, and that's a certification that you can take and become a menopause practitioner. And, you know, the average age of menopause is 51 in the United States, but symptoms start 2 to 7 years before. And guess what the first symptoms usually are night sweats and insomnia. So, hello, brings us back to Ambien. But your insomnia that you might be experiencing could be that early shift of the hormones that's happening, because essentially a half of a woman's life will be lived after menopause. So it's not like we're trying to say this is a transition, and the hormone shifts that you're experiencing are a transition into menopause where you're going to live half your life. So my research is really focused in specifically on estrogen throughout the whole lifespan of a woman's body. We definitely know there's a condition in young women. These are women in their 20s and 30s that are your dynamic, overachieving women who are just in college or in graduate school or in the start of their career. They might be a little more stressed than usual. They might be over exercising because it's a good stress relief, or they might be under eating because they haven't had time to eat, or just restricting their calories. And that's a condition that can result in their periods stopping. And it's a condition where your body says, all right, look, you're not giving me enough nutrients and you're stressed out too much. I'm going to shut off the ability for you to get pregnant. So it's actually a form of infertility. And it's a reversible form. But what is interesting about this is the levels of estrogen, because the ovary's pretty been much, on protest. It's shut down because of all the stress, because of all the exercise, and because of all the under eating, that these estrogen levels fall so low, they're similar to menopause. So we have women in their 20s and 30s, their estrogen level is similar to menopause. And we know that these women are at increased risk for bone fractures because we see that their bones thin. But it's only been recently that we started looking at heart health, because we know that women under the age of 50 should have their own estrogen. And women who go into menopause early and don't replace with estrogen, we know that they have a higher uptick in heart incidence. So we know that a body's own estrogen level, that those reproductive years, which is approximately 35 to 40 years of a woman's life, that woman should have estrogen in their body. So when you shut down that system in your 20s and 30s, you're doing more damage, not only to your bones, but now we're looking at heart health. So my initial research has shown that. We showed that there is an early signal of preclinical. So preclinical means that they're not getting symptoms. They're not having, these dynamic symptoms of shortness of breath or chest pain or back pain or gut. But we are seeing that there's an early signal, because essentially heart disease is a cascade. It happens not just overnight, but over decades. And when you start with this, it's the first domino that's gonna fall. And then you get so you get to see that changes. And so my research now is focusing on these young women and this area of infertility. And should we be giving women back a patch of estrogen while they're recovering from this? The good news is when you hit that first domino can be stopped, and we can stop the cascade from happening. That's the good news. But the research needs to be out there. And this is where the NIH put out a calling to do research on infertility. And because this is a form of infertility, is it a marker for future health in women? So while we know and we've learned a lot about menopause and heart health in an older woman who's transitioned through menopause, we now need to turn and focus to what's happening in the 20s and 30s, because this is what's setting us women up for dying of heart disease in your 40s, 50s, and beyond. So that's my special interest in research. We have a lot of research here at Cedars-Sinai. If you're interested in getting involved in research, even as a normal, healthy woman, we have studies that are involved that are looking at heart structures of the heart, because women's hearts are structurally different than men. There's a reason for that. Our hearts are a little bit stiffer than men because we have to childbear. Not all women childbear, but our hearts are structurally formed to have a stiffer infrastructure, because we have to accommodate for the demand of being pregnant, where the amount of blood circulating increases by 40% because you're feeding it to a second or third, sometimes you're twins, child. So we structurally are looking at the differences between men and women in the heart itself. So lots to do and lots of research. So that's my area of interest.
Another really great takeaway. I think we all know young women, or maybe we were young women who stopped having our period for a while because, they're exercising too much or stressed or whatever. And a lot of women just shrug that off like it's not important if you stop getting your period. And we should know that is a really a bad sign, and something that they should be concerned about for their health later. For women, I know there's going to be a lot of women here today. You just mentioned come down to Cedars and get involved in some research. I have a feeling that there's going to be a lot of people with hands like, yes, yes. Women have so many menopause questions, and I really get the sense that either they can't ask their primary care physician, or they don't feel that they know, or they don't feel that their gynecologist knows. So I just wanted to, before we get into questions, ask you, where at Cedars, can you tell us about the program that you're running, and is there availability for women to come, women like me in their 40s who are either into this or know they're going to be coming into this soon? How can we get involved there and make sure at least that we're getting the care that we need, or at the very least a checklist, so we know what questions we should be asking our doctors? How do we get that information?
Yeah, and so I mentioned, and even if you have somebody that's not in Los Angeles, you can go to menopause.org and find a menopause practitioner. So you just put in your zip code and the area that's around you, and you can find somebody that's certified in this area of menopause. But
I didn't even know a menopause practitioner exists.
And that needs to get out there too, because it's perimenopause and it's midlife women's health. And that's why this program was open. The program was opened about 11 years ago to really answer the question, what do I do about hormone therapy, or how do I handle menopause, or what? I have women come to seek information. Look, I'm 41 years old. I want to know what's going to happen over the next decade to me. And I want information so I can be aware of what to expect, because we know that things shift at menopause. We know that not all women are appropriate for hormone therapy, especially if you've had an estrogen positive cancer, like a breast cancer or an ovarian cancer, or if you've had a heart attack, or you've had a stent placed. We know that there's some more risks involved with being on hormone therapy. So the purpose of this program was to really address in the need for women to get more information and have somebody that's an expert in not only heart health, but also menopause, that can kind of put the fuller picture together. Because you're right, gynecologists might not have that time. Internal medicine doctors might not have been trained. So you need somebody to kind of bring that marriage together and say, look, this is what the facts are, this is what the risks are, this is what the benefits are in terms of what you're going through. So that's where the program really thrives. I see patients on Mondays. I wear several hats, as you mentioned. So, but I do see women that seek information or second opinions. And I always say, your gynecologist remains your gynecologist. Your internal medicine doctor, if you don't have one, I'll find one for you, but will remain your internal medicine doctor. I will become your midlife women's health menopause specialist. So, I work for the hospital at Cedars-Sinai. I'm not in private practice. So, but that gives me the ability to then, therefore, spend a lot of time and go through all the details in terms of what menopause is. And it might be anything from hot flashes, night sweats, to painful intercourse, vaginal dryness. These are all issues that should be addressed. And a lot of doctors are not talking about it. Gynecologists might be doing your annual exam, but they might not be asking, are you having pain with intercourse? Because that's one of the first tissue that's impacted by low estrogen levels. So, and then therefore that decreases libido. So there's a lot of symptoms that are true related to menopause. And there's a lot that aren't. And it's important to get the right information out there. And it's the Google, if you go to Dr. Google, he'll tell you anything. And you got to go to vetted sites that are well validated. And you also have to go somewhere that is, menopause is the #1 Googled word, by the way. And so there's no surprise that Dr. Google has a lot of answers with it. But go to sites that
we're going to get good answers from Dr. Google. So I think the takeaway from this is that we actually need, if we have the ability to, and fortunately, if for those who are here in LA, or if you're in a major city, as you mentioned, or if not, you can go online. But I think what I'm hearing here is that if women really should, in their 40s, seek out a separate menopause doctor just to deal with that issue of their health, because our gynecologists aren't necessarily going to give us the full scope of knowledge on what we might need to know for this, and that there is this option available to us.
Yeah, exactly.
So when you hit 40, or whenever you start to feel flat, the first symptoms, this is what we're heading over to Cedars to see you. I want to open the floor to some questions. And I know, but really quickly, just I don't want to take too long on COVID, but just a quick a quick flash of COVID. Is there anything, you and I had a quick chat about how COVID actually is infecting women and men a little differently. Can you give us any quick tips on COVID that we should know?
All right, my quick tips on COVID. I'm giving an hour lecture on this tomorrow, so I'll be very quick. More men are dying of COVID than women. More men. It's almost a 2-to-1 ratio. And this was seen originally in Wuhan, China, and it spread across Europe, and now it's in the United States. And not the virus spread, but also this ratio spread. So more men are dying. More men are in the ICU than women. 70% of men that get it, 70% of the ICUs across our country are men, rather opposed to women. Now, why is that? There's a lot of hypotheses out there. One is that women have better social norms. We are more likely to wear our mask. We're more likely to wash our hands more often, and we're more likely to social distance. Women are also, but we're also the care providers for our family. So we're more likely to be exposed to somebody with COVID, right? Because we're caring for our providers as well as our community. 90% of the women in this country are healthcare providers, of the nurses, 90% are women. So you've got more women on the front lines, but less women getting the severity of the disease. Men and women are actually getting COVID at the same rates, broken down by age, at all age ranges. More men, more women and men at every single age, 10-year age bracket are getting it at the same rate, but less women are dying from it. The other theory is our immune system. We have a stronger immune system than men, and this is also an area of my interest that needs to be studied. It has a lot to do with estrogen, but guess what? It holds true after menopause when you don't have estrogen in your body. And it is, the fact of the matter is our, the immune markers that fight COVID and fight viruses are on the X chromosome. Guess what? We've got 2 X chromosomes and men only have 1. So we already know that women mount a better response to vaccinations because of that. Women have a better response to viruses. If you have a man and a woman in an ICU at the same day, women are more likely to recover and be discharged earlier, and are less likely to be dying of that. So this is why COVID is actually doing better in women than men. So take heart, that's a women's health advantage there, but it also is the fact that more women get autoimmune diseases. So you hear like things like lupus or rheumatoid arthritis, those are autoimmune diseases. Well, it's likely because that's an overactivation of our immune system that puts us also at a little bit more disadvantage because those immune cells are on our X chromosome. So all good information and all interesting information coming out of, even though it's a pandemic and we've all been really hunkered down, and a lot of mental health is coming out now as we've been isolated for so long. But take note, we definitely are at an advantage from this infection.
So fascinating. And it's funny because just as you're talking, I'm getting texts from attendees who are asking me, is this being recorded? Is this being recorded? Because I need to watch this again. So people are loving this information. I'm looking in the chat and I'm seeing some questions, and there's a lot of questions around hormone replacement therapy.
Yes.
And I know that obviously for women, I'm 47. And I know at my peer age, this is something, when it comes to menopause, the first thing we think about is hormone replacement therapy. Should we do it? Should we not do it? What are the potential implications in terms of cancer? There's one question that asking you what you think of the pellet hormone replacement and general plant-based hormone replacement. Yep. Research linking that to cancer. So how do women really access this information about hormone replacement therapy, yep. Whether or not they should do it, especially if they have a history of breast cancer in their family? Because I think that's what a lot of us women are afraid about when we think about, because it seems like such a cure-all, right? Like, menopause, well, if I just take hormones, I won't have to experience all these horrible things. But
I know, and it was a great hypothesis. Like in the 1970s, actually, they thought that because what happens at menopause, estrogen levels go down, and what happens at menopause is heart disease rates goes up. So it was a working hypothesis that if you give a woman back estrogen, then her heart disease rates will go down. And but that was only based on animal studies and really observational studies, which aren't our gold standard. It wasn't until the 1990s that the first clinical trial was done. 1990s was a big year. In women on hormone replacement therapy. And it was really a clinical trial because that's our gold standard, right? That's our gold standard where you compare the active drug to the placebo drug. And then we learned that it probably isn't protective. But even before that, guess what? If we thought hormones protected heart disease, The first clinical trial was done in a man. They randomized 3,000 men to estrogen therapy. So isn't that ironic? Like that to me just blows my mind. If they thought estrogen protected heart disease, who did they study it in first? Men. They gave it to men. They did a placebo-controlled trial where they gave men estrogen and versus the placebo, and after 3 years, more men got blood clots than those that were on placebo. So they stopped the study early. But here's the guidelines, and this is where my expertise, and I'm an advocate for women's health, but I'm also a national, I sit on several national academic committees, and I'm president-elect of the Menopause Society. So, and I'm also on the writing guidelines for the 2021 hormone replacement therapy guidelines, which is basically what sets the goal for our guidelines for menopause hormone replacement therapy. Here's what we've learned, and we've learned a lot since the Women's Health Initiative, which was a study that was the study I referenced in 1990s. That study was done in older women. That was a study that was trying to determine, does estrogen prevent heart disease? So by default, they did not enroll women who had hot flashes, because if you enrolled a clinical trial to women who had estrogen that were having hot flashes, they'd know within a week if they got placebo. And guess what? They'd probably drop out. So by default, they did not enroll women that were at the age of menopause. So they enrolled women that were a lot older. And because they were older, they were starting hormones older, 10 years after menopause, they had higher rates of heart disease. That does not mean that if you are healthy at the time of menopause, suffering from menopausal symptoms, and you are free of contraindications for taking hormone therapy, then you are appropriate to take hormones. We're learning a lot about the different types of hormones, the different makeup of hormones. There's something called bioidentical. That just means that it's similar to what your body used to produce in the ovary. It's an estrogen that is similar in structure. It's usually a plant-based, which is made from either a plant, a yam, sometimes a peanut, so you can have a peanut allergy for some of the progesterones. And they're called bioidentical. So they're available on your prescription plan, meaning that you will pay your prescription plan every year. So they're available by the FDA. They've been available since the 1950s. They weren't really what's been studied. We are now looking at them more. They still bind to the estrogen receptors, just like synthetic estrogen. But there's no need to go to a compounding pharmacy because they're available on your prescriptions and patches and gels and pill forms. So bioidentical are available on your prescription plan. So you don't need to have a pellet inserted. You can go get it from your, in a patch form or a pill form from your prescription, and you don't have to pay out of pocket anything more than what your deductible is. I will speak to the fact that the pellets are not FDA approved. That formulation was never FDA approved. It was brought to the FDA about 20 years ago, but it hasn't been approved for a route that's considered for safety of delivery. And one of the reasons is because if you insert a pellet and get a pellet of estrogen every certain number of months, every woman, I already mentioned this at the beginning, we metabolize drugs differently. So there's not only is there a difference between how we metabolize to a man, but there's a difference between each individual woman based on your ethnic background, based on the way that we metabolize drugs is differently in intra women. So how I metabolize estrogen might be different than the next person that metabolizes estrogen. One of the concerns with the reason the FDA did not approve pellets is because they're irreversible. So, imagine if you get a pellet inserted and, 2 weeks later, that pellet's dissolved, you can't remove it, and you get a horrible diagnosis of an estrogen positive breast cancer. Wow. Well, the oncologists cannot remove that pellet because it's now dissolved into your system and it's active, and that pellet can be active. They say every 3 months, but I've seen them last much, much longer, especially if you're getting pellets inserted every 3 months, every 2 months. That level can compound and add on in some women. So the safety issue is what is a concern with me with pellets, especially when you get these very high levels. We know that high levels of estrogen are associated with blood clots. We already know that. We know birth control pills in young women, it's a small risk, but that risk increases as you get older in terms of your risks of developing a blood clot. So, and by the way, an estrogen is an estrogen. I will say 80% of this country, if you're a woman, you've taken a birth control pill, and those are synthetic estrogens. So synthetic estrogens are not all bad. And I think a lot of synthetic estrogens got a bad rap after the Women's Health Initiative, but there are other formulations, like I mentioned, the bioidentical, that are available by your prescription plan that don't need to go to an outside compounding pharmacy. So that's a long-winded answer.
It's a great answer. And now we see, by the way, why we can't get all this information from our general practitioner or even our gynecologist, because there's so much to cover. I do have a couple questions about birth control pills. Do the risks of birth control, of taking birth control, as you mentioned, a lot of people, most women at some point of their life have taken birth control. Do those risks continue into later life, or do they stop once you stop taking the pill? And does the length or duration of time that you take it, I think the question is, does this have an effect?
Yeah, so we think birth control pills are relatively safe. I just want to say that, because but there are some considerations you need to take into account. Actually this week I have a paper in our medical journal called JAMA. It's a clinical insight that I talked about birth control pills and high blood pressure, because birth control pills is one of the reasons blood pressure can go up. So we need to be cautious about that. We need doctors to be aware, and this clinical insight in JAMA was to educate doctors about that fact. The second thing is that birth control pills prevent pregnancy, and one of the biggest risks in our country, before heart disease became the #1 killer, if you look at a lot of developing countries, birthing is, women die in childbirth. So there's a reason we need birth control pills, but there's other formulations that are available if it's not a good fit for you. In terms of heart health, we think that the biggest risk is probably within that first year of taking it, in terms of the blood clotting risk. But if you've been on it for a long period of time, it's not done any damage or any concern in terms of that to your heart. It's not protecting your heart, but we know that there's no concern in terms of the longer you take it. Now, what that does to fertility and how that impacts fertility once a woman stops, because it can mask underlying conditions, right? It's not a real period you're getting, it's a fake period. The week of the placebo pill that you take was actually by design, because they didn't want women to think, oh, I'm not getting a period, could I possibly be pregnant? So they actually built in that 1 week of a placebo period that you get a withdrawal bleed. It's not a true period. So, but it can mask other conditions. It can mask the condition that I'm studying, that condition where stress kind of shuts off the ovary. Because if you're getting a fake period every month, you might not think, oh, my overwhelming stress or my eating or my exercise might not be doing damage because I'm on a birth control pill, because I'm still getting my period, but it can mask things. So that's where I get the concern. We haven't seen a signal with breast cancer, but it is a caution if you have a family history. The same thing's true for hormone replacement therapy. That is a true relationship. So we do know after 5 years of being on hormone replacement therapy, it is the risk of breast cancer. And the risk is 3 out of 1,000 more women will get an early diagnosis of breast cancer every year after 5 years of use, compared to 1,000 women not on hormone therapy. So that's considered a very low risk, but it is a risk that's there. Now, if you have a family history of breast or ovarian cancer, you do need to talk about that to your doctor, because that puts you in a different bracket. And if I have a clustering of a woman comes in and she might have a maternal aunt and a cousin who had ovarian cancer, if there's a clustering effect, I usually send women for our excellent genetic screening here at Cedars-Sinai. We do an excellent job in our cancer center. It's a panel of multiple genes, not just the BRCA1 and BRCA2, which is the common ones that we know about. They do, there's much more in-depth genetic testing that can be done these days. So you can then be aware and armed with what needs to be done. It might not be as extreme as going for a mastectomy or getting your ovaries removed, the Angelina Jolie effect, but it could be as extreme as, look, a mammogram's just not right for you. You've got to get a breast MRI. That looks a little bit more detailed at the tissue. Now, should every woman go out there and get a breast MRI? No, because it does pick up things that are incidental. And we don't want a woman who's very low risk to go get a breast MRI and then be told, oh, she's got a little nodule in there. We got to go in and biopsy it, because it's probably unrelated. But you're at high risk or at higher risk of getting breast cancer. That's when the screening MRIs are key and are actually covered by insurance. So I could speak to this for a whole, another hour talking about breast health, but certainly it does speak to the fact that there's a lot of considerations to be taken into, whether it's birth control pills or whether it is menopause. And I'll just also briefly say that if you're not a candidate for either birth control pills or menopause hormone replacement therapy, don't suffer in silence, especially menopausal or perimenopausal. There's a lot of alternatives that are what we call non-hormonal options to treat menopausal symptoms. And I will share with you this because I'm on the board of the Menopause Society, and I kind of get to hear what's in the pipeline. There's a new drug that's in the pipeline. They just finished phase 3 trial on it. It is going to change the way we treat menopausal care. It is remarkable. It's not an estrogen. It is, it works, you know, in the area of the brain that controls your central thermostat. That's actually the route of where you start a hot flash. It works on these neurons. They're called candy neurons. How nice is that? Very sweet. Candy, K-N-D-Y. It's kisspeptin, neurokinin, dynorphin. You don't need to remember that. There will not be a test. But it does speak to the fact that these are the neurons that control our central thermostat. And they've now discovered a drug that can actually not shut that off, but at least get it back into balance so that your thermostat's not swinging from 106 down to 62. It's kind of back in that normal central range of, you know, 72 to 68, which is where everyone kind of wants to sit at, right?
Dr. Shufelt, this is extraordinary. First of all, I love your answers because in that last answer, you answered, I think, 6 separate things that people were messaging to me to ask. So I love these long answers because you're covering so many bases. And I know everyone still has so many questions that we could honestly, as you say, go on for hours or days. But I am certainly sure that, unfortunately, we are a little over time now. So I'm going to cut it off. But I know that everyone on this call is going to be calling Cedars-Sinai tomorrow and trying to get in to see you. So we're going to continue the conversation for sure. This has been an extraordinary hour. Thank you so much for your time. We would love to have you. There's lots of appreciation and thank yous. And thank you for sharing and working at Cedars with all these women. And we're just really lucky to have an incredible physician like you in our orbit here that we can access. Thank you.
I thank you so much for the opportunity to talk. I would be happy to speak with anybody, answer any questions. If you want to come see me, I'm more than happy to see you. Mention visionary. You're a visionary woman because I do have a little waiting list, but I will get you in right away. If you do want to come see me, I will end on the fact that women are boots on the ground. We put our money where our mouth is. We make changes to guidelines. We make changes with research, and this is where women's health needs to be changed. So I'm hoping to platform a survey across specifically in California to really make a difference in educating doctors for women's health. So I thank you so much for having me. And these were excellent questions, and I appreciate it.
Thank you so much.
Thank you. Thank you, Dr. Shufelt.
Thank you so
Chelsea,
much.
also for inviting me. You're fantastic.
Oh my God, it's so much food for thought. We're never going to go into a doctor's office the same way, right? Once it's you know, you can't unknow it once you know it, once you realize. And you know, it's not like it's malicious, right? It's not like our doctors are trying to not give us the best care. It's just, as we said, it's baked into the system. So once we're aware, we can just start asking more questions and making sure we get the care we need until those systems change, like you said.
Exactly.
Thank you.
Right. Have a good day, everybody.
Thank you, Dr. Shufelt, so much for your time. I'll be calling Cedars to make our appointment soon.
Thank you.
Bye, everyone. Thanks for joining us.